All right, let's jump right in. Today, we are going deep into the official clinical playbook for treating adult cataracts. This is the preferred practice pattern from the American Academy of Ophthalmology, and we're going to unpack the entire evidence-based path that guides pretty much every step of modern cataract care.
Right at the beginning, the guidelines hit you with this really clear, definitive statement, and it sets the tone for everything that follows. What it means is that, based on tons of evidence, once a cataract actually starts causing symptoms that mess with a patient's life, the answer is surgery, plain and simple.
So the big question is, how do we get there? In this explainer, we're going to walk through that exact clinical pathway. We're going to follow the guidelines step by step to see how ophthalmologists figure out if a cataract is really the problem, how they plan the fix, and then how they carry it out.
Okay, first things first, we need a little bit of context. To really get the treatment, we need to be crystal clear on what a cataract actually is and where it comes from.
So a cataract is basically any clouding of that natural clear lens inside your eye. It blocks and scatters light, and that's what makes vision blurry. Now, the guidelines are super clear on the major risk factors. Things like diabetes are a huge contributor. And then you've got lifestyle stuff, like smoking, and of course, environmental exposure to UVB light. Another big one is long-term use of corticosteroids. Doesn't matter if they're pills, inhalers, or even eye drops. That's a well-known risk.
All right, section 2. This is our first real deep dive, the diagnosis. And let me tell you, this is way more complex than just having a patient read an eye chart in a dark room. It's really about figuring out the real-world impact of that cataract on their vision. The AAO lays out this whole diagnostic toolkit. Yeah, you start with a standard eye chart test, the CDVA, but, and this is crucial, it also includes glare testing to see what's happening in real-world situations. A slit-lamp exam lets the doctor see the cataract up close and personal. Measuring the intraocular pressure, or IOP, that's a must. You also have to check out the surface of the eye, tear function, the shape of the cornea, because that can affect everything. And finally, you've got advanced imaging like macular OCT, which is often absolutely critical.
And this right here shows you why that standard test isn't enough. A patient could read 20/25 on a chart just fine, but be totally visually disabled when they're driving at night and a car's headlights hit them. Glare testing mimics these exact kinds of stressful visual situations. It gives a much more accurate picture of how bad the patient's vision really is, and that helps justify moving forward with surgery.
This also shows why we need to look past the cataract. You have to ask, is the blurry vision only from the cloudy lens? Macular OCT imaging is essential for spotting other problems, maybe in the retina, like an epiretinal membrane or some swelling. Finding these things beforehand is so important for managing a patient's expectations. It basically answers the question, how much of the vision problem is the cataract and how much is something else?
So, once the diagnosis is confirmed and we know the cataract is the culprit, we move into the planning phase. And success in this stage is all about one thing: precision.
A huge part of that planning is getting the math right for the new lens, the intraocular lens, or IOL, that's going to replace the cataract. The guidelines point specifically to modern, super accurate formulas. We're talking newer generation ones like the Barrett Universal 2 and even the Hill RBF, which uses artificial intelligence. These advanced calculations use a bunch more data points to hit the perfect prescription after surgery with just incredible accuracy.
Now, not all IOLs are created equal, and the material they're made of has real-world consequences. Let's just walk through this table. Hydrophobic acrylics are really common. They have a low rate of a late complication called PCO, but they can get these little glistenings, so that almost never affects vision. Then you have hydrophilic acrylics. They have a higher PCO rate, and this is a big warning from the guidelines. You have to avoid them in patients who might need a gas bubble put in their eye for retinal surgery because the lens can actually calcify. And finally, silicone lenses. They also have a low PCO rate, but you want to steer clear if future retinal surgery is a possibility because the silicone oil used in those surgeries can stick to the lens and just ruin the view.
Anesthesia is another one of those key decisions, and it's a real trade-off. On one hand, you have topical or intracameral anesthesia, basically numbing drops and medicine inside the eye. Super low risk. The downside is the patient is awake, they can see things, they can feel pressure. On the other hand, you have an injection behind the eye. This gives much better pain control, but it does carry some rare but very serious risks, like poking the globe or causing bleeding.
All right, we've diagnosed the problem, we've planned the solution. Now it's time to head into the operating room for the surgery itself.
The guidelines put a huge emphasis on preventing infection, especially a really devastating but rare complication called endophthalmitis. The protocol is like a multi-layered defense. First, you have to know where the enemy comes from. It's almost always the patient's own bacteria from their skin and eyelashes. Second, the single most important defensive move is putting 5% povidone iodine in the eye before surgery. And third, a lot of surgeons add another layer of protection by injecting an antibiotic right into the eye when the case is done.
And the guidelines don't just say use an antibiotic, they're very specific about which ones have been studied for this. The most common are cepafloxacin and moxifloxacin. Vancomycin is also on the list, but it comes with a huge warning label. It's been linked to a rare but severe type of retinal toxicity, so it has to be used with extreme caution. The go-to surgical technique, the standard of care, is something called phacoemulsification. I mean, this is a true marvel of microsurgery. It uses high-frequency ultrasound to basically liquefy or emulsify that cloudy lens into tiny pieces, and then it just vacuums them out. The beauty of this is that the whole thing can be done through a tiny, self-sealing incision, often less than 3 millimeters wide. That means faster healing and less astigmatism. It's pretty amazing.
So, for our final section, let's talk about what happens after surgery. Now, cataract surgery is one of the safest and most successful procedures in all of medicine, but no surgery is totally risk-free, and the guidelines are meticulous about how to handle any potential issues.
This chart really helps put the risks in perspective. If you look at a huge study, the rate of really bad, sight-threatening complications is incredibly low. We're talking endophthalmitis in just 0.16% of cases. Retinal detachment in 0.26%. For anybody thinking about having this surgery, these numbers are incredibly reassuring. They're solid proof of just how safe this procedure is.
Now, the most common thing that happens after surgery is something called posterior capsular opacification, or PCO. Let's break that down. Posterior just means behind the new lens. Capsular refers to that little natural membrane, or capsule, that's left behind to hold the lens. And opacification just means it got cloudy. The most important thing to know is this is absolutely not the original cataract growing back.
And the good news? The fix for PCO is super straightforward, and it works great. It's a quick, totally painless, in-office laser procedure called an end-diag laser capsulotomy. The laser just creates a little clear opening in that cloudy membrane, and that instantly gives the light a clear path to the retina again, bringing vision right back to where it was after surgery. The guidelines also cover a few other things to keep an eye on. You can get temporary spikes in eye pressure, which you have to manage. Sometimes there's swelling in the retina called cystoid macular edema, or CME, which usually gets better with anti-inflammatory drops. You also watch for swelling of the cornea, the new lens moving out of place, or strange visual images called dysphotopsias. So if you boil this entire clinical pathway down to one crucial takeaway, it's this. The whole process revolves around the patient's real-life experience. The decision to do surgery isn't about some random number on an eye chart. It's a conversation. It's a decision you make together when the patient's vision, because of that cataract, just doesn't let them do the things they want and need to do anymore.
And that leaves us with a final thought. We are seeing just incredible innovation in lens technology right now. Lenses that can fix astigmatism or give you a wider range of focus. So the big question for the future is, how will these really strict, evidence-based guidelines keep evolving to help surgeons use all that new technology to get even more personalized, even more amazing results for every single patient?